Hi guys, welcome back to week 9. This week we are focusing on the GI tract, gastrointestinal tract. Again, this is a focused review and summary. I just wanted to pinpoint some of the key things that I felt was really important that you focus on for both your clinicals and your NCLEX, your boards review. Please use this in addition to the PowerPoints that are already posted. That's more in depth. This is more of a focused review and summary. Okay, this chapter focused on the GI tract, and I just wanted to focus on the fact that and reiterate that the GI tract serves as the point of entry for nutrients, fluids, electrolytes, and many medications and drugs. GI disorders are very common in the US, with abdominal pain being the cause of over 27 million office visits annually. Disorders of the GI tract are categorized as alterations of digestive function, alterations of absorptive function, alterations of immunologic function, or alterations of neuroendocrine function. Following an overview of GI structure and function, this chapter and this PowerPoint breaks the discussion down by location. So as you're going through your readings and you're going through the PowerPoints, you're going to notice that we break down abdominal pain by location because properties and disorders of the upper digestive organs are addressed, and followed by properties and disorders of small and large intestines, followed up by the wrap up of lifespan considerations. So one thing leads to another when it comes to the GI structure and function and the disorders. So here we go. Of the main points I wanted to just reiterate. So again, just as always, like I like to break down whatever organ system I'm reviewing in terms of the basics, in terms of their structure and function. So here's a very quick video to just overview the GI structure and function. So hopefully this will play. I don't know why it's not. Let's give it 1 second, honey. Let me just see if I can. Here we go. Quick video just to review the basics.
Across the whole planet, humans eat on average between 1 and 2.7 kilograms of food a day. That's over 365 kilograms a year per person, and more than 28,800 kilograms over the course of a lifetime. And every last scrap makes its way through the digestive system. Comprised of 10 organs, covering 9 meters, and containing over 20 specialized cell types, this is one of the most diverse and complicated systems in the human body. Its parts continuously work in unison to fulfill a singular task, transforming the raw materials of your food into the nutrients and energy that keep you alive. Spanning the entire length of your torso, the digestive system has 4 main components. First, there's the gastrointestinal tract, a twisting channel that transports your food and has an internal surface area of between 30 and 40 square meters, enough to cover half a badminton court. Second, there's the pancreas, gallbladder, and liver, a trio of organs that break down food using an array of special juices. Third, the body's enzymes, hormones, nerves, and blood all work together to break down food, modulate the digestive process, and deliver its final products. Finally, there's the mesentery, a large stretch of tissue that supports and positions all your digestive organs in the abdomen, enabling them to do their jobs. The digestive process begins before food even hits your tongue. Anticipating a tasty morsel, glands in your mouth start to pump out saliva. We produce about 1.5 liters of this liquid each day. Once inside your mouth, chewing combines with the sloshing saliva to turn food into a moist lump called the bolus. Enzymes present in the saliva break down any starch. Then your food finds itself at the rim of a 25-centimeter long tube called the esophagus, down which it must plunge to reach the stomach. Nerves in the surrounding esophageal tissue sense the bolus's presence and trigger peristalsis, a series of defined muscular contractions. That propels the food into the stomach, where it's left at the mercy of the muscular stomach walls, which pound the bolus, breaking it into chunks. Hormones secreted by cells in the lining trigger the release of acids and enzyme-rich juices from the stomach wall that start to dissolve the food and break down its proteins. These hormones also alert the pancreas, liver, and gallbladder to produce digestive juices and transfer bile, a yellowish-green liquid that digests fat, in preparation for the next stage. After 3 hours inside the stomach, the once shapely bolus is now a frothy liquid called chyme, and it's ready to move into the small intestine. The liver sends bile to the gallbladder, which secretes it into the first portion of the small intestine, called the duodenum. Here, it dissolves the fats floating in the slurry of chyme so they can be easily digested by the pancreatic and intestinal juices that have leached onto the scene. These enzyme-rich juices break the fat molecules down into fatty acids and glycerol for easier absorption into the body. The enzymes also carry out the final deconstruction of proteins into amino acids and carbohydrates into glucose. This happens in the small intestine's lower regions, the jejunum and ileum, which are coated in millions of tiny projections called villi. These create a huge surface area to maximize molecule absorption and transference into the bloodstream. The blood takes them on the final leg of their journey to feed the body's organs and tissues. But it's not over quite yet. Leftover fiber, water, and dead cells sloughed off during digestion make it into the large intestine, also known as the colon. The body drains out most of the remaining fluid through the intestinal wall. What's left is a soft mass called stool. The colon squeezes this byproduct into a pouch called the rectum, where nerves sense it expanding and tell the body when it's time to expel the waste. The byproducts of digestion exit through the anus, and the food's long journey, typically lasting between 30 and 40 hours, is finally complete. TED Ed is a nonprofit. If you value our work,
So
please
hopefully this
consider
was a
supporting
quick
it on
overview
patreon.com/TEDEd.
and helpful just visual demonstration of the overview of the GI structure and function. So some things I just wanted to point out too, like just as a major, minor just review, the GI tract is the route of ingestion of food and water needed to sustain life. Very basic fact, okay? The process of physically and chemically breaking down complex components of a mixed diet into small molecules suitable for absorption occurs over many centimeters of gut length and square meters of surface area. Specialized secretions and smooth muscle motility patterns characterize the segments of the GI tract, which includes the mouth, pharynx, esophagus, stomach, duodenum, jejunum, ileum, colon, rectum, and anus. However, there is an underlying similarity among most of these structures. They are hollow tubes with an inner lining, a mucosa, surrounded by smooth muscle layers and finally wrapped in an outer adventitia layer. Regulation and coordination of activity along the GI tract includes neural, hormonal, and local influences. Okay, so let's continue on. All right. So I just wanted to review some basic facts about digestion and absorption. I wanted to make sure that you are grasping and have an overview of macronutrient and digestion and absorption versus principles of micronutrient absorption and principles of fluid and electrolyte absorption. Okay, so remember, digestion reduces large, complex dietary components to small molecules that are then absorbed, and proteins are broken down to amino acid, and small peptides and carbohydrates are broken down to small sugars. Fat digestion and absorption is the most complex process, with hydrolysis of triglycerides, phospholipids, and cholesterol esters to their component molecules, assisted by bile salts provided by the liver. Remember, bile salts secreted by the liver and gallbladder are required for fat digestion, and absorption. Another thing that I wanted to make sure to point out is that body fluid balance depends on absorption of liquid from the diet. In the course of each day's meals, many liters of fluid are secreted by the GI tract segments and that are then reabsorbed. So small intestine water secretion involves the cyclic adenosine monophosphate, or CAMP, regulated by chloride channel cystic fibrosis transmembrane conduction regulators, or the CFTR. And another thing I wanted to just point out is that when a patient is experiencing an excessive amount of diarrhea, you need to keep in mind that diarrhea results from an excess of GI secretion, hypermotility, and presence of undigested osmotically active particles and malabsorption. Diarrhea with bleeding is also associated with certain GI infections and irritable bowel disease. Okay, so we're going to get into the differentiation of irritable bowel syndrome versus irritable bowel disease versus celiac disease. Okay, it's very important that you are able to differentiate the symptoms of the three. Okay, so abdominal pain patterns. So important. Abdominal pain is a common reason for seeking medical treatment, and specific syndromes have characteristic pain patterns that inform follow-up testing and management. For instance, irritable bowel syndrome presents with recurring pain in combination with altered defecation patterns. So the pathogenesis of irritable bowel syndrome is not usually fully understood, but the disorder is functional without structural markers. So in terms of approaching abdominal pain, this is so important for you to really just consider in your clinical practice that, you have to realize abdominal pain is such a common complaint in both acute care, the emergency room, clinics, wherever you are.
It's
working.
7:00.
And before we even deal with the questions like the physical exam and the lab tests, the one thing you have to ask is what structures are in the abdomen and how can these things cause pain? So, with any type of pain, you want to think about what is in or near the region of interest and what might cause any of these things to be painful. So when we look at this particular diagram here on the right-hand corner, you want to look at what is in the abdomen. So in the GI system, we have the stomach, the small intestine, the large intestine, the liver, the gallbladder, the pancreas. Then we have the urinary system, which includes the kidneys, ureters, and the bladder. The reproductive system, which includes the female's ovaries, uterus, and the male's testes. And keep in mind with males, the testes descend from the abdomen. So if they're having pain in the testes, a lot of the times it can be referred pain from the abdomen to the testes. We also have the spleen and the blood supply to all of these organs from the abdominal aorta and its branches, as well as the abdominal wall. So the next question you're assessing when you're looking at abdominal pain complaints and symptoms is, how can each of these particular organ systems be painful? So when we look at the organs of the abdomen, we divide them into tubes. So we have the gut, the fallopian tubes, the bile duct, the ureters. And then we have the solid organs like the liver, the pancreas, the spleen, the ovaries, the kidneys, and the blood vessels. Okay. So one of the things you have to consider is, what can make the abdominal tubes hurt? One cause is obstruction. So we say to ourselves, okay, what can obstruct these tubes? So kidney stones can obstruct ureters, and gallstones can obstruct bile ducts. So the GI tract can also obviously become obstructed. So an appendicitis is usually due to obstruction from a fecalith or hypertrophy of lymph tissue in the appendix. Another common cause of bowel obstructions are adhesions or scarring from previous abdominal surgery. Other causes of obstruction include tumors, hernias, and volvulus, which is like twisting of the intestines around itself. Other thoughts that you need to consider are like the fallopian tubes. If a female patient of, you know, you want to consider that her fallopian tubes may be obstructed. Any female patient of reproductive age with abdominal pains needs a pregnancy test. Definitely keep that in mind. Always just 100%. If you have a woman coming into you, no matter what the symptoms are, really, one of the first things you want to consider is she of childbearing age, and could she possibly be pregnant? You want to just, without hesitation, go ahead and just do a pregnancy test just to make sure. You want to keep in mind that pregnancy itself can cause abdominal pain, and so can tubal or ectopic pregnancy when the pregnancy is inappropriately implants in the fallopian tube or somewhere else in the abdomen. What else might obstruct the fallopian tubes? Pelvic inflammatory disease or any kind of STDs, where there's an infection of the female reproductive organs that often presents as lower abdominal pain. Common culprits of lower abdominal pain in terms of female reproductive organs are gonorrhea and chlamydia. So the other thing to consider also in terms of STDs that pus or abscesses can also obstruct the tubules. And why is it that obstructions are so painful? You want to keep in mind that any obstructed tube builds up pressure behind it, and this squeezing of the tube against resistance leads to the phenomenon of that cramping. So additionally, torsion or herniation can lead to ischemia of the tube or the in question. And keep in mind, tubes can also cause pain if they perforate. So for example, a gastric or duodenal ulcer that can perforate, which can happen very commonly in ischemic bowel or diverticulum. I want you to also keep in mind what can make the solid organs hurt. So any organ with a tumor, whether it's benign or malignant, can cause pain due to stretching of the organ's capsule or pressure on adjacent structures. So anything that could cause inflammation or swelling could be painful. And causes of inflammation in abdominal organs could include the bowel, which includes inflammatory bowel disease, gastritis, colitis, or your liver, which could include hepatitis, whether it's viral, autoimmune, or alcoholic hepatitis. Obviously, your pancreas with pancreatitis, kidney infection like pyelonephritis, or your spleen as an infarction with sickle cell, as well as ovaries like with an ectopic pregnancy. All of these pressure type organs that are causing pressure because of their underlying issues could definitely cause pain. So just always keep in mind when it comes to patterns of the abdomen, where exactly is the pain originating from, and could it be referred pain? All right, so another thing I wanted to make sure that you reviewed and are very conscientious about understanding are malnutrition and obesity. Malnutrition is a common concern globally and can encompass undernutrition manifested by underweight or overweight with nutritional deficiencies. Now, keep in mind, obesity has a number of associated health risks, including type 2 diabetes, mellitus, metabolic syndrome, and non-alcoholic fatty liver disease. Obesity management strategies include lifestyle changes, weight loss drugs, and bariatric surgery. Although rates of obesity are increasing worldwide, some regions appear to have reached a plateau. Okay, so another big thing I wanted to make sure that you're being conscientious of in terms of understanding and differentiating the difference is the difference between IBD and IBS. So irritable bowel disease versus irritable bowel syndrome. Okay, it's so important, I feel like, for people to make sure they're differentiating them because it will have a big impact on how you not only answer your review questions or your board questions, but also how you treat clinically. So symptoms to look for in terms of IBS, you want to look for it's more of a functional disorder. Sometimes the GI symptoms are kind of vague, but usually you're looking at constipation, diarrhea, or a combination of both, as well as abdominal pain and cramps. You do get gas. Obviously, it's exacerbated by stress, emotions, food, medications, hormones, um, versus IBD, where a lot of the times you don't get as many symptoms, so to speak, in more that you get symptoms that are much more severe in terms of uh, you'll get fevers, weight loss, bloody stools, and chronic diarrhea. So the symptoms that you could definitely notice in terms of variations, IBS versus IBD. In IBD, you'll definitely see more systemic things that are going on in terms of like weight loss, bloody stools, chronic diarrhea, fevers, more systemic symptoms versus these more acute symptoms that you would see in irritable bowel syndromes, which are more abdominal pain, cramps, gas, things that are more in the moment as opposed to long term chronic issues. Okay, so another big thing I wanted to make sure we're reviewing and just talking about very sincerely is H. pylori, which is found closely associated with gastric mucosa and causes chronic active gastritis, gastric and duodenal ulcers, including peptic ulcers, and could develop into adenocarcinomas. So I just wanted to play a quick video just to review it because I just felt like it was so important to talk about. So here's a quick visual recap on H. pylori infection.
Today's topic is Helicobacter pylori infection. Helicobacter pylori, or H. pylori, is a type of bacteria. These germs can enter your body and live in your digestive tract. After many years, they can cause sores called ulcers in the lining of your stomach or the upper part of your small intestine. For some people, an infection can lead to stomach cancer. A common cause of peptic ulcers, H. pylori infection, may be present in more than half the people in the world. Complications. Complications associated with H. pylori infection include 1. Ulcers. H. pylori can damage the protective lining of your stomach and small intestine. This can allow stomach acid to create an open sore or ulcer. About 10% of people with H. pylori will develop an ulcer. 2. Inflammation of the stomach lining. H. pylori infection can irritate your stomach, causing inflammation, also known as gastritis. 3. Stomach cancer. H. pylori infection is a strong risk factor for certain types of stomach cancer. Symptoms. Most people with H. pylori infection will never have any signs or symptoms. It's not clear why this is, but some people may be born with more resistance to the harmful effects of H. pylori. Some symptoms include an ache or burning pain in your abdomen, abdominal pain that's worse when your stomach is empty, nausea, loss of appetite, frequent burping, bloating, unintentional weight loss. If you have an ulcer, you may feel a dull or burning pain in your belly. It may come and go, but you'll probably feel it most when your stomach is empty, such as between meals or in the middle of the night. It can last for a few minutes or for hours. You may feel better after you eat, drink milk, or take an antacid. One should reach out for medical help on symptoms like stool that is bloody, dark red, or black, trouble breathing, dizziness or fainting, feeling very tired for no reason, pale skin color, vomit that has blood or looks like coffee grounds, severe, sharp stomach pain. Causes. The exact way H. pylori infects someone is still unknown. H. pylori bacteria may be passed from person to person through direct contact with saliva, vomit, or fecal matter. It may also spread through contaminated food or water. Risk factors. Risk factors for H. pylori infection are related to living conditions in your childhood, such as living with someone who has H. pylori infection, living without any proper supply of clean water, living in crowded conditions, living in developing countries. Treatment. If you have ulcers caused by H. pylori, you'll need treatment to kill the germs, heal your stomach lining, and keep the sores from coming back. It usually takes 1 to 2 weeks of treatment to get better. Your doctor will probably tell you to take a few different types of drugs. The options include antibiotics to kill the bacteria in your body, such as amoxicillin, clarithromycin, or bioxin, metronidazole or flagyl, tetracycline or sumicin, or tinidazole or Tindamax. You'll most likely take at least 2 from this group. Drugs that reduce the amount of acid in your stomach by blocking the tiny pumps that produce it. They include dexlansoprazole or Dexilant, esomeprazole or Nexium, lansoprazole or Prevacid, omeprazole or Prilosec, pantoprazole or Protonix, or rabeprazole or Acifix, bismuth subsalicate, which may also help kill H. pylori along with your antibiotics. Medicines that block the chemical histamine, which prompts your stomach to make more acid. These are cimetidine or Tagamet, famotidine or Fluxid, Pepsid, nizatidine or Axid, or ranitidine or Zantac. Thank you for watching our video. Please do not forget to like and share the video. Also, please subscribe to the channel to stay updated on our latest video.
All right, so just a few things I wanted to make sure that we're understanding in terms of the role of H. pylori. I just wanted to make sure that we understand the mechanisms involved in the gastric acid secretion and the role of H. pylori within it. So just keep in mind, gastric acid secretion by parietal cells depends on the membrane proton pump that uses ATP to move 1H plus out of the cell in exchange for entry of 1K plus or potassium. Acetylcholine and gastrin stimulate the protein pump activity working through the C system and calcium, and local histamine release acts through G and the adenyl cyclase system to stimulate acid secretions. These 3 agents work synergistically to promote acid secretion while a meal is in the stomach. After the stomach empties, levels of these mediators decrease and local prostaglandin levels increase. Prostaglandin inhibits further acid secretion and promotes increased blood flow to sweep away excessive acid that has entered the mucosa. This occurs in 3 phases. So management of hyperacidity conditions such as GERD and peptic ulcers rely on protein pump inhibitors and histine H2 inhibitors. H. pylori is not a part of the normal flora of the GI tract. So when H. pylori is present, it can colonize regions of tissue damage and withstand the low pH levels, which creates inflammation that promotes recurrent ulcer formation until the infection is eradicated by antibiotics. So this is why it's so important to recognize the H. pylori infection and get the patient treated with antibiotics as soon as possible. Next. Okay, so the next thing I wanted to just review is gastric acid secretion. One of the things I wanted to make sure we're differentiating and understanding is the difference between celiac disease versus irritable bowel disease versus irritable bowel syndrome. So I just figured a review of this would be super helpful, just to really reinforce the mechanism of gastric acid secretion.
Secretion of hydrochloric acid. Davenport theory. Hydrochloric acid secretion takes place in the canaliculi of the parietal cells and gastric glands. Energy for this process is obtained from oxidation of glucose. Carbon dioxide is derived from metabolic activities of parietal cell and from blood as well. Carbon dioxide combines with water to form carbonic acid in the presence of carbonic anhydrase. Carbonic acid is a very unstable compound and splits into hydrogen ion and bicarbonate ion. The hydrogen ion is actively pumped into the canaliculi of the parietal cell. At the same time, chloride ion is also pumped into the canaliculus actively. The hydrogen ion combines with the chloride ion, which is derived from the sodium chloride in the blood, to form hydrochloric acid. To make up for the loss of chloride ion, the bicarbonate ion from the parietal cell enters the blood and combines with sodium to form sodium bicarbonate. Factors stimulating the secretion of hydrochloric acid are gastrin, histamine, Vagal stimulation. Factors inhibiting the secretion of hydrochloric acid are secretin, gastric inhibitory polypeptide, and peptide Y.
Okay, so that was just a super simple, quick review, and just a few things I wanted to point out. Like, we wanted to make sure, I wanted to make sure that you understand, the comparison of the celiac disease, IBD and IBS, the pathophysiology of each, the clinical presentation of each, and the assessments and diagnostic and testing that are needed for each one. Okay, so I just wanted to point out, so celiac disease is an immune disorder where there's an exposure to gluten proteins in wheat, barley, and rye initiatives, which causes an immune response. In children, you're going to see a slowed growth. That is what they exhibit when it comes to celiac disease. In adults, which it may not display till later on in their life in terms of celiac disease, they may present with weight loss, chronic diarrhea, anemia, and possibly osteoporosis. In terms of diagnostic testing to evaluate for this, you want to begin with blood titers for IgA to TG2. If this is positive, an endoscopy for biopsy will provide a definitive diagnosis. Now, in terms of IBD or irritable bowel disease, it includes both ulcerative colitis and Crohn's disease. So remember, IBD includes ulcerative colitis and Crohn's, all right? Both involve an immune dysfunction that causes impaired tolerance to normal microbiota and hyperactive immune responses that result in inflammation of the mucosa. Crohn's disease has a greater propensity to cause transmural lesions and potentially fistulas, whereas ulcerative colitis can cause more extensive but superficial denuding of the mucosa and can result in greater blood loss than Crohn's disease. Keep in mind that both Crohn's disease and ulcerative colitis have patterns of exacerbations and remissions. Both may present with other immune disorders such as primary sclerosing cholangitis, pericholangitis, pyoderma gangrenosum, erythema nodosum, seroconjunctive arthritis, or ankylosing spondylitis. An endoscopy, imaging studies, and biopsy are used for diagnosing. IBS has few structural manifestation, but instead is more of an acute visceral hypersensitivity causing abdominal pain and alterations of constipation and diarrhea. The thing about IBS is that the exact etiology is unknown. However, it may include abnormal gut motility, increased inflammation, and stress. However, both the IBD, IBS, and celiac all distribute those as well. Early stressful life events are implicated in altered pain thresholds. That's specifically more with IBS. And the patient will present with severe abdominal pain coupled with either constipation or diarrhea or both. So diagnosis is really, really based on history. So you really want to differentiate their symptoms so that you can make sure to differentiate whether it's IBD, celiac, or IBS. All right, guys, that's it for this week. Those are the main things I wanted to make sure to reinforce with you so that you can make sure to review them, not only for your practice and your clinicals, but for your boards as well and your midterm exam. So hopefully this was helpful, and I will see you guys next week. Have a great week, guys. Thank you.